everyone. Today we're going to discuss some GI. This is our first week, so we're going to look at cases involving the esophagus and stomach. Here again is the disclaimer that we have at the beginning of all of these lectures. So feel free to peruse this when you're looking at the recording. If you have questions, I'm happy to answer them about this. And okay. So, relatively simple. We're going to have some benign lesions, some malignant lesions for both esophagus and stomach. A lot of these are entities that I myself have found challenging, so hopefully they're not quite as challenging for you guys. Let's get started.
Alright, this first case looks like a biopsy. Looks like at low power we have some possible squamous mucosa here. A little high power, look around, have a look-see. Well, even at this power, you could kind of appreciate there's a lot of red, even for like sort of the old staining of the slides. Like this looks like blood, but maybe not. But there's just, it looks like at low power. I mean, you could say, wow, this guy's bleeding like crazy, but it might not be once you go to high power because it's eels. Holy cow! Eels, and these are all eels here. I think.
Yeah, quite a few of them.
Well, I've never seen a case this bad before. So
that's why I chose this case. I kind of wanted, this is, when you think of this entity, this is what you
This is never this textbook. Eosinophilic
you
esophagitis.
do see some of them, yeah. Okay.
I have yet to.
Alright. So do we need to say anything else about this? This is eosinophilic esophagitis.
Well, we have to give it an eosinophil count, don't we? I think.
That is correct. And the sources do vary a little bit. But yeah, generally it's like you want to give a count, and then if this was a recurrent biopsy, then you'd want to compare to the previous, so that the clinicians can see, like, is the treatment that we're doing or the change in diet working, even more so with peds, because kids can't always voice what's going on. So that's a good parameter to look at. Excellent. Okay. So you nailed it. So actually this is relatively infrequent, less than 0.1% of the population. We tend to see most of these cases in adults, but a good amount of them do happen in peds. When they do occur in children, they're far more likely to occur in males than females. And you can kind of see the difference between adults and peds, whether they're gonna complain about dysphagia or heartburn, indigestions, that feeling of food getting stuck in your esophagus as you're trying to swallow. Whereas kids, they might just be really nauseated or throwing up all the time, or just complain about vague abdominal chest pain. And that, of course, is, you know, if they're vocal, if this is happening in babies, then you might just have a fussy baby. And this occurs in Caucasians more commonly than other ethnicities. On endoscopy, so I tried to correlate as much of these findings with endoscopy as I could for you guys. So this is where they will talk about the trachealized esophagus. So they'll actually develop concentric rings in almost half the cases. Sometimes they can have longitudinal furrows or fissures, and they can even have what's known as crepe paper mucosa, and that's just kind of where it's really friable, looks granular, and you may even see things that are white plaques that when you examine them, they actually tend to correlate with either pinpoint papules or exudate. And pretty much what was described on microscopic is what you're going to see is a lot of eosinophils within the esophageal mucosa. And I have it written here again, the cutoff will vary, but generally you should be seeing more than 15 EOs per high power field in at least one biopsy. And what happens when we're talking about this gradient present is that your EOs should really be higher in the superficial epithelium compared to the base of the epithelium, and then they may be present in the stroma. But again, it should be most prominent on the surface, because if it's food irritants or allergens or anything like that, it's on the surface. So that's how you need to correlate that. Some people would say that the following are pathognomonic features. So I leave that up to you guys reading some papers and kind of deciding for yourselves what you think about that. But if you see a lot of microabscesses with clustered EOs, that also can correspond to those little white plaques or papules that they see on endoscopy. If you have eosinophil-rich superficial desquamation, or eosinophils that are degranulating or losing that major basic protein. And remember, the major basic protein is involved with like mast cells and histamine release and all that kind of allergic stuff. Some things that you could see is, well, it's inflammatory, right? So you could see a lot of lymphocytes, and if you do see them, they're going to be CD8 T cells. You can also see mast cells. Depending on how long this has been going on, you could see fibrosis or hyalinization. So also think about that if you have trachealization or if the patient has to undergo dilation of the esophagus. Another thing to consider too is that if they've been dilated is that they could perforate the esophagus after they've been dilated. And then I have some of the findings here listed for eosinophilic esophagitis and gastroesophageal reflux disease. And in the handout, when you guys pull that up, which is attached to this presentation in Path Presenter, I do have GERD in there for you guys so that you can compare that. Lots and lots of EOs in those pictures. Okay, so your differential, not too surprising, is gastroesophageal reflux disease or PPI responsive esophageal eosinophilia. And obviously for the history with that, they would have to have a history of taking PPIs. That's not something that you would just suggest without having clinical history. Treatment, they tend to try and change their diet if it's related to food allergens, but remember, if they're doing something like this, they have to ID what that patient is responding to. So whether it's gluten or some types of maybe it's proteins in dairy products or whatever it is, but that has to be identified. And then off-label treatment, you could try ingested corticosteroids, and for really bad cases, they could do systemic steroids. But PO corticosteroids tend to work better. And then for prognosis, it's basically the entire range of everything. These patients can even resolve spontaneously with or without treatment. But do keep in mind that, remember when we said that if you dilate, there can be cases of perforation, so you have to consider things like Boerhaave syndrome, so Boerhaave being rupture of the esophagus, whereas your Mallory-Weiss tears are tears in the esophageal lining resulting in bleeding. I put a trichrome stain because I thought that was really interesting to see how you have your epithelium up top and then a really fibrotic, densely fibrotic stroma, and that would be related to trachealization or previous dilatation for stenosis. And then just more pictures of EOs. Okay, case 2.
Bunch of pieces from a biopsy. At low power, it's really not too exciting, but higher power, you do appreciate there's a lot of like blueness.
Yes.
Very blue. A lot of, I would say, inflammatory cells probably. It's not projecting too well. Lymphocytes.
Lots of lymphocytes, yes.
Okay. There's the muscle there, I think. Or is that is that a really wrapped up squamous?
There you go.
It's probably
Yeah.
wrapped up squamous. Never mind. Spongiotic. Maybe?
Yeah, it's not happy.
It's not happy. It's okay, yeah.
And why is it not happy?
Well, there's a lot of inflammation, a lot of erosion. It's kind of like fraying at the ends here. Right?
Yeah. That probably is the best piece on this.
Yeah. I mean, this one's kind of pretty much destroyed over here. You're not even seeing any epithelium, so it could be an ulcer, it could just be a bad sample, we don't know, but lots of inflammation.
go back to that first piece, yeah, that one.
Mm-hmm.
And then, so take a look at the way the epithelial cells are streaming, and then what's going perpendicular to them. That might be the easiest way to see it. And it won't be easy to see at low power.
Okay.
Do you see them now?
Like these things?
Yeah.
It's kind of hard to tell, but would it be like some sort of organism?
That's a very good thought.
Like,
So what kind of things really like to attack or colonize the esophagus?
Candida.
Candida, yeah.
Stain. You could do a GMS stain to bring it out, or maybe a PAS.
Yeah, I like both of those stains.
So I would say if it's positive, it's probably Candida. Kind of has that look to it. It's a bit of like this pseudo hyphae type thing.
Yeah, it kind of through the projector, it almost kind of looks like they're ghosting over top. I think it's a little easier to see on your computer screen. But yeah, this is Candida, just
Florid.
everywhere.
Florid.
Yeah, because you can even tell, so like if you stop for a second, so like you have your Candida forms, and then you have as well like your budding forms there too. So you have the whole gamut in this thing. And I've actually never seen one this florid. So again, just thought it was a really nice example for you. And then yeah, the squamous epithelium is extremely reactive. It's not happy with this. There is some ulceration, like maybe a little granulation tissue in some spots. So that's what this is. So this is the most common infection of esophagus, so important to know because we see it all the time, and Candida albicans is the most common. So these patients will complain of it hurts when I'm trying to swallow, it's difficult for me to swallow, but they can also present with really vague GI symptoms, like maybe they have some indigestion or epigastric pain or like a little bit of nausea. So the clinical history isn't always super helpful with this. On endoscopy, they're going to see what I have on the top right, which is these really thick white plaques. But these plaques are easily removed on endoscopy, so when they see this on endoscopy, they'll actually try to scrape some of it off, and underneath they'll have that ulcerated erythemic mucosa, and from what we've seen on the microscopic view, we can understand why. So on microscopy, you can see variable inflammation. Remember, if your patient is severely immunocompromised, so think of your cancer patients, your transplant patients, your HIV patients, they might not have much of any inflammation going on because they cannot mount an immune response. But if there is inflammation, there tends to be a lot of neutrophils, which can also be intraepithelial. So neutrophils and lymphocytes, and those neutrophils forming a superficial band is more common in Candida than in reflux or GERD. So remember when we were looking at the eosinophilic esophagitis and we were seeing eosinophils, so eosinophils more common in GERD and reflux than neutrophils. You may or may not see an abscess or ulcer or necrosis, and sometimes you can have pseudomembranes, which is, I think, also what we had in that previous case. Very rarely you'll find granulomas. And then I have a little bit about the different variations of Candida, but realistically, to sign this out, you would just say like something like consistent with Candida species. You don't have to be necessarily that specific. And then again, the inset is just showing you again, like here's our pseudo-hyphae stain. So yeah, we have very exciting GMS and PAS, which will highlight them extremely well. You'd want to think of different fungal infections, so aspergillosis and histoplasmosis. The fungal infections also think about what's common in whatever area of the world you're in. And you can also have colonization by Candida, and this would be very superficial, so you wouldn't have the very verbose, florid reaction that we saw in that case. Obviously, they're going to treat them with antifungals, and these will be like the oral swish and swallow type treatments. And the prognosis, often these are treatable and the patients will respond. However, there is risk of dissemination or fungal sepsis or fungemia if it's severe and if the patient is immunocompromised. So you do want to take these seriously, but they are something that you see quite often. Okay, case 3.
Okay, I see dots, so.
Yes, I couldn't hide the dots.
Okay, so this looks like there's some squamous epithelium here. Not much in the way of mucosa, but coming down here, you do get some sort of columnar cells, epithelium, a mix of squamous and columnar cells here. So I'm gonna say we're at the G junction probably,
Okay,
possibly,
maybe.
depending on where the endoscopy said they got it from.
There you go, yes.
Yeah. So let's just pretend this is at the G junction, but let's just pretend. So we have a bit to work with, I guess. I do see these, like there's these sort of goblet cells, looking cells. It's not projecting as well, but normally if there's like blue or mucin, I would assume they would contain.
Yeah, they're
well, this one's a little
bluer
better.
compared
Yeah.
to other
Um,
cells.
So because it does have that intestinal look to it, not really a gastric look, more of intestine. So this would be some sort of intestinal metaplasia. You would also have to evaluate if there's any dysplasia. It's a little hard to tell, but I don't think there's any. It's a little hard to tell here. It kind of got squished, but you would check for if there's any dysplasia. And if there is, you should mention it. Otherwise, you would say not seeing any dysplasia.
Okay,
I mean,
and what do you mean by dysplasia?
Like, probably just atypical nuclei cells, loss of polarity. I mean, it's hard to tell because some of these cells do look like bigger, like higher NC ratio, a little darker, but I'm not sure if that's from processing or just it's not projecting well. So,
Yeah, that's fair.
Yeah.
It's totally fair.
I mean, just based on this, I'm kind of say there is some dysplasia, even though it seems like there is still like they're preserving their orientation, but it's just some of these nuclei just looks kind of off.
Okay, what else is in the stroma?
Stroma. Like inflammatory cells,
Yeah,
plasma cells,
yeah.
so a little wrapped up.
It's
Probably.
maybe a little revved up.
Mhm.
So, I think you still need to look for dysplasia, but
Yeah.
you also need to hold back a little bit when you start seeing inflammation.
Yeah. I mean, it's not too bad. This can be accounted for probably from inflammation, this degree of sort of slight atypia.
Right.
So I'm going to say no dysplasia. So
Okay.
you would say intestinal metaplasia negative for dysplasia, and then you would add a note. You have to correlate with endoscopy because you can only call
Okay,
it.
let's, okay, yeah, I know where you're going with the note, because this is drilled into us.
Dr. Willis is
Yes.
drilled this.
So let's say this is mid-esophagus.
Mid-esophagus. So then you would probably say, well, I don't know the actual how it would work the note, but you would say this is Barrett's esophagus. So
Yeah.
because
Yeah.
it's what, like 1 centimeter, how much above the GE junction?
Right, yeah, it has to be at least 1 centimeter superior to the gastric folds.
Oh, okay.
Yeah. But yeah, so obviously with these cases, they don't give us the endoscopy side of things, so we kind of have to interpret that. But this level of intestinal metaplasia in the esophagus, and by this we're presuming that they're above that 1 centimeter threshold, this would be consistent with Barrett's. Excellent. So Barrett's esophagus. So this happens in 10 to 20% of patients with long-standing gastroesophageal reflux disease. So not 10 to 20% of your population, but people with GERD. It's almost always in adult males. And just like with GERD, they're going to complain of heartburn. They may have a cough from the reflux, but they can also be asymptomatic. So risk factors, obviously, if they have GERD, if they're male, over 50 years old, and Caucasian males, and also obesity. So on endoscopy, they have some very specific findings that they can talk about, whether it's the salmon-colored tongues, where they're really like this fluffy pink color, rather than like it's more hyperemic than regular esophageal mucosa. It'll be very velvety because it's undergoing change and it's irritated. And you'll also have regularity of the Z line, which becomes more and more prominent with other things that can occur. So what you're seeing on the endoscopy is the empty arrowheads are pointing to the salmon tongues that are coming towards you, and then it looks like maybe there's also a superficial ulcer at the curved arrow. Microscopically, the definition of Barrett's esophagus is intestinal metaplasia or columnar epithelium with goblet cells within the tubular esophagus with endoscopic correlation. So that's where we were talking about that it has to be more than 1 centimeter superior to the gastric folds. And then, as was also mentioned, you need to look at whether or not there's dysplasia, and you must report whether or not dysplasia is present. If it's present, whether it's low grade or high grade dysplasia. And on the microscopy on the lower right, I just have some examples of non-dysplastic Barrett's. You do not have to stain this, but if you really wanted to, you can see PAS positivity or Alcium blue positivity, but these need to be also used with caution as they'll be incomplete and scattered. There's a whole bunch of molecular that can be associated with Barrett's, so keep that in mind. The differential obviously is, as we were saying, if you were at the G junction, is this just intestinal metaplasia of the gastric cardia, which is fine? Are these actually esophageal submucosal glands, which can mimic Barrett's? Same with gastric foveolar cells. And depending on where the sample is and how they did the endoscopy, you also need to consider if there was carryover from the small intestine. So if everything's completely detached, you might want to consider that. So for treatment, they tend to give them PPIs, antacids, they can do H2 blockers, and if they want to be more definitive, they could try doing mucosal resection and ablation. These patients are going to go surveillance for this because there's estimated annual risk of progression to adenocarcinoma. It's relatively low when they first are diagnosed. So for the first 5 years, it's 0.1 to 0.3%. So it's, you know, it's not too terrible. But as soon as they're around 20 years of having Barrett's esophagus, then that risk annually is 9 to 9.5%, and those numbers are from the American Gastroenterological Association. On the top right, we have a PAS stain, so you can see how it's really highlighting those goblet cells from the intestinal metaplasia and how it's really scattered. And then just a few more examples, so you can see how polarity is maintained, but those goblet cells should still be very prominent. Okay, malignant lesions. Okay. So the caveat to this is this patient presented with a skin nodule. So this is a skin nodule. So what is the history? Because I know you're going to zoom in on this and you're going to be like, what?
Skin nodule.
Yes.
Okay.
Unfortunately, there were no primary locations of this, so I had to go for metastasis.
Oh, okay. So this is from skin.
Yes.
Okay. I see. Yeah, I was looking. I was like, this is a very weird biopsy. Like,
yeah, I know. I'm sorry.
All right. So yeah, we have skin. Ooh. That's not supposed to be in the dermis. What do you have here? It's forming glands.
Yes.
Not supposed to be here.
Yep.
So it's going to be, and the cells look really ugly, so it's an invasive carcinoma. And then it's from gland, so adeno.
Yep.
And then I guess you'll just have to look at the history and see where this came from, if this is a metastasis.
So you don't have any pathology, but this patient has a history of a partial esophagectomy 10 years ago.
Okay, so partial esophagectomy for cancer probably?
Most likely.
Okay, so that would be the number one suspicion.
Yeah.
And in terms of like, we will throw some stains to confirm your suspicion. Esophageal stains. Actually, I don't know esophageal stains. What do we have here?
All kinds of stuff. But yeah, the point is you see something like this, unless you have definite history, because very often with stuff like this, it could come in where the patient has this skin nodule, but there's also lung nodules. There's something funny going on in the liver that they haven't been able to test, and they have all these histories in their past, or surgeries in their past history. So yeah, stains would be your friend. So this is really just a nice interpretation of, okay, we're thinking. Please wait, this information is loading. There we go, okay. So adenocarcinoma, and very nice ulcerated lesion at the gastroesophageal junction. There was one that I saw the other day on Twitter where a resident had posted a gastric ulcer that looked very similar to this. At least grossly. The microscopic was completely different, but okay. So adenocarcinoma involving the esophagus has increasing incidence across the United States. This tends to be older adults, again, males more than females, and pretty much if you wanted to make a bet on it, it's going to be a male over a female. Just like our GERD and Barrett's esophagus, they're going to complain of dysphagia, retrosternal epigastric pain, and obviously the pain comes with more advanced lesions. Risk factors are very similar to Barrett's esophagus, so males with Barrett's esophagus, that's what B stands for, obesity, if they have tobacco use, and really there shouldn't be a history of, it should be NSAIDs or PPIs or statin use. Okay, we got some typos I need to fix. On endoscopy, this is either going to look like a flat patch, it could be nodular, it could be ulcerated like what we're seeing there, and there may be some background Barrett's esophagus. So, so think about all the endoscopic findings that you could have with Barrett's, including like the tongues, whether they have little ulcers and the irregular Z-line as well. On microscopic, it's going to be an infiltrating tumor with variable formation, either gland or more acinar, could have mucin. You often can see intestinal metaplasia with it, and you may even see squamous metaplasia or squamous differentiation. Occasionally these can be associated with Epstein-Barr virus. If there is Epstein-Barr virus involvement, then you would also have a lymphoepithelial pattern. You can also see small cell carcinoma or high-grade neuroendocrine carcinoma with these. Are polarly differentiated, so when we think signet ring cells, this is where that comes in. You can have pagetoid spread, so think of your pagetoid involvement, so just spreading along the base of the epithelium. It can have papillary architecture, and you can also have involvement of Panna cells. And you may or may not have background dysplasia or intestinal metaplasia, so it shouldn't bother you too much if you don't see that, because if it's obvious carcinoma, then that's what it is. Stains. Lots of them again, so your PAS, Alcian blue, mucicarmine. Okay, well, this presentation has problems that I need to fix clearly. CK7, CK19. So CK7 would be the one to stand out versus your negative CK20. Amicur can be positive, somatostatin, serotonin, and variable HER2. Your molecular is going to be exactly the same as Barrett's esophagus, so no surprises there. Your differential is going to be, is this Barrett's esophagus with high-grade dysplasia? Is this actually a gastric adenocarcinoma, or is it an adenocarcinoma from somewhere else? Treatment, they're going to excise it, and they're going to do chemoradiation. If it's really small T1 lesion, which means like, is it just simply intramucosal or superficial submucosal involvement, they could consider doing ablation, whether it's radiofrequency cryoablation or even just doing a mucosal resection. And they can also do preventative therapies with these, which would include your PPI, aspirin, and NSAIDs and statins. So all those things that were in the history as the patient shouldn't have use of this for risk factors are actually things that they can use as preventative treatments. 5-year survival for this is relatively good. It's relatively poor. It's the PT1 5-year survival is relatively good at 65 to 80%. And if it's actually a T1A, the 5-year survival is greater than 90%, but overall, the 5-year survival is about 35%, as many of these will present at high stage. Okay.
So another biopsy, some sort of mucosa at low power. Something funny here, maybe. Let's just go in. Okay. So this piece, squamous mucosa, some muscles, nicely inked, deep margin. It's kind of edematous, like what is going on here? We'll come back to it. Let's go over to this area that looks more exciting. It's very cellular, very high or very low NC ratio, lots of cytoplasm. The cells kind of look like almost epithelioid, sort of.
Okay, yeah.
They're kind of, and looks kind of like granular.
Yeah.
Or is it just not pretty?
No, it's definitely granular.
Okay. The edges looks not really, doesn't look, I mean, it sort of has an edge, but it's kind of not that well circumscribed.
Okay.
It does seem to have a border, but it's kind of like fuzzy. Not really seeing capsule, I guess, is what I'm getting at.
Definitely, okay. No capsule.
So, but it's, a lot of these cells is kind of forming a mass. I would say it's some sort of tumor. And it's granular.
Mm-hmm.
So putting them together, granular cell tumor.
Okay, excellent. Yeah, so you can really appreciate all the granules that are part of the cytoplasm, even though some of the cells are falling apart. Okay.
And the other sections is just like kind of edematous.
Yeah, it's that non-specific edema that you really should not mention. So esophagus is your most common GIT site, but these gastrointestinal sorry. But granular cell tumor only accounts for, in the esophagus, only accounts for 2% of all granular cell tumors. So this is still really uncommon. Again, adults around 40 years old, but this one is more common in females than males, so that's something to keep in mind. It's also more common in African Americans than Caucasians, so we finally hit a lesion that's not as common in Caucasians. And often these are incidental findings. If they get very large and they cause obstructive symptoms, then they can be symptomatic. On endoscopy, it's just going to be a sessile lesion, could be yellow-white, and they tend to be firm, but your surrounding epithelium is going to be intact. So unlike a lot of the other lesions where we were saying, well, it could be friable surrounding it, it could be ulcerated, the epithelium should be intact. These are well-circumscribed, firm lesions that will look more white on cut section. Microscopically, they do not have a capsule, but they should still be well-circumscribed. So, meaning that they don't have very infiltrated borders. And they should be submucosal, which you could also see in the previous case. The cells themselves are relatively monotonous, as we saw. They do have that abundant granular cytoplasm. To me, it looked more eosinophilic in that case, but typically it's more amphiphilic or a little more purplish. The nuclei tend to be small, and you may or may not even see pycnotic figures, so don't let that scare you if you see that. And you'll see occasional nucleoli, but they shouldn't be very prominent, and it shouldn't be every cell. Your superficial squamous mucosa may or may not have pseudoepitheliomatous hyperplasia, and that happens in about 50% of your cases. If you need a refresher on pseudoepitheliomatous hyperplasia, then I do believe we covered that this series in the derm lectures. There are malignant variants of granular cell tumors, so that would be lesions that have grown really rapidly. They're very large. They have tumor necrosis. They're even more hypercellular. There's obvious nuclear atypia and more mitotic figures. So nothing that we saw in ours looked malignant. For your stains, again, these are another PAS positive lesion. They also will have S100, SOX10, TFE3, calretinin, CD68, and inhibin positivity, whereas your muscle markers, so your MyoD1, myogenin, will be negative, and the other stains that you would use for melanoma will also be negative. So whether you like HMB45, MART1, melanate, those should all be negative. For your molecular, the molecular association, which is the TFE3 ASPCR1 fusion that you see in alveolar soft part sarcoma, will not be present in this lesion. And that's something that's important to note, because it does tend to look like alveolar soft part sarcoma, and it does have TFE3 positivity. So that's something that can help you there. Besides the alveolar soft part sarcoma and melanoma, you might also want to think about rhabdomyoma, but again, all those muscle markers are going to be negative. They're just going to cut this out, and again, because a lot of them are incidental, they usually are excised fully at the time that they're taken out. And almost all of them are going to be benign, but there are rare reports of malignant granular cell tumors, so you would want to watch out for the features of malignancy that we talked about previously. So just to highlight again, the S100 should be really strong, really diffuse, and when you see that in the SOX10, don't forget to run some other melanoma markers to make sure you're not looking at a melanoma. Okay, the stomach.
Biopsies, I see a duck, so let's focus on that. I like ducks. Okay, first you determine the type of mucosa here. This kind of looks like antral type mucosa.
Mm-hmm.
Not really seeing any pink sort of parietal cells and purple sheaf cells. Anyways, let's see what we have here. So it doesn't look, I mean, it's at low power, it kind of looks a little bit disorganized.
Okay.
Maybe a little, not as much inflammation, maybe some, but not like diffuse inflammation. Higher power, you notice some of the sort of epithelial kind of, there's lots of mucin,
Mm-hmm.
and maybe some weird stuff going on here.
What about all this stuff?
What is that? It's not projected very well.
It's not projecting very well, but what do we spend a lot of time hunting for?
Like H. pylori?
Yeah.
Really? This inflammation.
It's not very prominent, but it
Yeah.
doesn't always have to be.
Okay.
And then to prove it, so if you go to the same area,
This is an H. pylori stain?
this is an H. pylori stain.
Oh, wow. Okay.
So some of this is probably like crushed and crud and stuff, but you have your little comma-shaped figures.
I always hated looking for H. pylori.
Yeah,
I'll tell
it's tough. You usually don't see a lot of it, but often you can see it on H&E, so you don't always necessarily need the stain, but it can be helpful. And maybe in a case like this, it's more helpful.
I gotta say though, like this case, just based off of degree of inflammation, is not what you characteristically expect.
Right.
Like you expect more active inflammation for
Yeah. And again, we don't get history, so it could even be something like maybe this patient has been treated and they were going back and it's like, no, it's still there. It does happen, so that might be what this is. But yeah, Helicobacter pylori, chronic gastritis. So we see a lot of these biopsies. It affects half the population in the world, obviously with increased incidence in lower socioeconomic status, but it can affect anyone, okay? This tends to be adults that are older than 50, and about 40% of these cases will occur in Western countries. Adults older than 50 in 40% of the cases in Western countries, sorry. 80% of these cases, so almost all of the cases, their patients are actually going to be asymptomatic. They may have maybe a slight anemia that gets picked up on a test. They might have, again, some indigestion, some nausea, or complaints of emesis. The Helicobacter itself is a gram-negative curved rod, so almost comma-shaped. And it can have virulence factors such as the VAC-A cytotoxin or KA, which is the cytotoxin-associated gene. And I have a little bit about how those affect, obviously, whether it's erosion or how the inflammatory response is coming across in the stomach. Grossly, this tends to affect predominantly the antral stomach. However, you can have pangastritis or body predominant. This is particularly helpful if the patient maybe has had this infection long-standing, or if it's a more aggressive strain, which would mean like it has like the virulence factors that are listed. So microscopically, you're going to have marked inflammation chronic that can form a superficial band. So I have a picture of a superficial band to the right of that. It may or may not be lymphocytic gastritis. You may or may not see neutrophils, and those tend to be present in the neck region of the glands, which signifies an active infection. You can see microerosions, but these will be superficial, and there can be foveolar hyperplasia. And when foveolar hyperplasia is seen, this is a regenerative feature. Again, just a reminder that usually it's confined to the antrum, but it can involve the body or cardia. Once treated, then you will no longer see neutrophils, and the chronic inflammation may or may not persist, but if it's present, then it should be mild. And you can see I have like really profound lymphocytic infiltrates there with germinal centers. Positive stains, so IHC for H. pylori, which is non-specific. You can do an antigen stool test, which has poor sensitivity. Or you could do the urea breath test, which is very specific but has high complexity. So not a lot of good things to help you out, not a lot of easy things to help you out. So the best thing to help you with H. pylori is actually your H&E slide. Your differential would include Helicobacter hellmanni, which instead of being short curved rods, they're corkscrew and longer, but they will also stain with H. pylori stain, so you have to keep that in mind. You need to consider autoimmune gastritis as well as focally enhanced gastritis. Treatment, they're going to do the standard triple therapy, which is a PPI, clarithromycin, and amoxicillin or metronidazole, and that will cure most cases. lifetime risk of ulcer with infection is 5 to 10%, but they are at increased risk of progression to gastric cancer, as well as you need to consider things like the malt lymphomas. For stains, I have your H. pylori IHC, as well as the Warthin-Starry stain, which is a silver stain. Nobody really will use the Warthin too much anymore, but it could be an option if you don't have access to immunohistochemistry and you want to ensure that there were bugs. And then the top H&E has some Helicobacter in the H&E. Not the best quality image, I admit, but it is there. And then the bottom is just showing the neutrophils at the neck.
Alright, next case. So it looks like some sort of mucosa and low power with a very blue epithelium. Oriented right? This is epithelium here?
Yeah.
Okay. So very blue epithelium, that kind of raises some eyebrows because you're like, shouldn't it be this blue? Going on high power, you can see that it is columnar cells, so it looks like gastric epithelium, but it's like so blue and really thickened, or it could be just a cut. I'm usually not used to it looking this thick before. So we have gastric mucosa. I'm just looking around, it's very blue, and blue is just like fluorid, like lymphocytes and maybe plasma cells circling through the stroma.
There's other stuff in the stroma.
Eels.
Lots of EOs.
Yeah, tons of eels.
And there's also other things. Think inflammation, but bigger cells.
Bigger cells. Like macrophages? Like B cells?
Like mast cells.
Oh. You don't see mast cells that often, so are those mast cells?
No.
No? Okay. Okay. Yeah. Mast cells is one thing I've always had issues with because
there's only a few of them, but yeah, they're
okay.
They're
Well,
large.
there's a lot of like mucin depletion here. There's even maybe some ulceration or well maybe not, but it could be just cut, but just mucin depletion, and there seems to be maybe some like atrophy going on.
I like where this is going.
So
what are you thinking?
The eosinophil and the mast cells and all this inflammation suggests maybe some sort of autoimmune function going on here.
Okay.
Autoimmune gastritis of some sort.
Yep. I mean, to be honest, autoimmune gastritis is something that I kind of struggle with myself. But I think this probably falls within the realm of early phase, just because there's so much inflammation. But really what helps draw you from thinking, is this another like H. pylori, do I need to run the stains, are the EOs and the scattered mast cells. I don't think there's a lot of them, but
Okay.
okay. So I have one more. Full screen. I can't tell you how many times I did that last week when it was just me. And all of these are good, so you can pick whichever one you like.
So help me with mast cells. I've seen it here and there.
Let's see if we see them in here. This one I think was more lymphoplasmacytic, because there's not even a lot of EOs in this one. But yeah, they tend to have, maybe there's some there, hard to tell, but maybe some of these guys.
Okay.
It's kind of hard to tell, but they should have, like, more cytoplasm, and they tend to be fluffier. Yeah.
Okay.
If somebody has something to add about mast cells, now would be a very good time to enter that. Or you can enter in the comments later on, and we can learn, and you can social media shame me for not reading up on that. But I don't really think that there are.
Yeah, but you can still appreciate this and increase the yields here.
Yeah.
In this field at least, so yeah.
Yeah, but I think we have more plasmacytic cells in this than anything in lymphocytes. But okay, so I thought maybe this was a little better representation of autoimmune gastritis because it's showing a little more of a little more atrophy. What I didn't really appreciate a lot of in either of these cases was the apoptotic bodies, but I think both of these probably still fall within the realm of early phase. But I do struggle with this, so always something that I need to look at quite a few times. So 1 to 2% of the general population, and increased incidence in Northern European, so Caucasian individuals. This tends to be adults greater than 60 years old, and again, females more than males, so the lesions that we've seen today that occur in females more than males are autoimmune gastritis, because autoimmune disorders are more common in women, but also that granular cell tumor in the esophagus. Patients will typically present with anemia as well. However, what type of anemia? E?
Anemia, like pernicious anemia?
Yeah. Yeah. Perfect. Okay, so pernicious anemia, which will be a megaloblastic anemia. Okay, on endoscopy, the mucosa is going to look very atrophic, so there's going to be loss of those mucosal folds in the body and fundus, and they may or may not have polyps. So I think both these cases fit within the lymphoplasmacytic infiltration. Again, if somebody disagrees, that would be great to either comment in the chat now or on the video later on. So the lymphoplasmacytic infiltration can either be basal, it can be diffuse, or it can be multifocal, and the difference is that this will be predominantly CD4 T cells. We are going to see EOs as well as mast cells, and also someone can point out if there's good areas of mast cells in these, because I didn't really see them. That would also be helpful. There may or may not be destruction of the oxyntic glands. That's where I was talking about. I didn't really appreciate a lot of apoptotic bodies. I think the first case had a few, but it was really very focal. And you can have mucous neck cell proliferation, as well as pancreatic hypermetaplasia and polypoid nodules as well. Okay. So I have a little bit in here about the florid phase as well as the end stage, and pretty much what happens is you get more and more atrophy and less inflammation as it goes along, and you can also get your ECL or endocrine cell proliferation. So this is important when you're thinking about, well, there's endocrine cell proliferation and then they're getting these polyps. These patients are also at increased risk of not only endocrine cell proliferation, but hyperplastic polyps. Okay, so for your stains, there's not really stains that are going to help you, but the lab tests that can help you is that the patient will be positive for either the hydrogen potassium ATPase and intrinsic factor. Their serum gastrin should be high, pepsinogen will be low, and vitamin B12 will be deficient. So that's where you get your antibodies to intrinsic factor, right? So they lose that, which results in a severe drop in vitamin B12, and that's where they get the megaloblastic anemia. Your differential is going to be multifocal atrophic gastritis, which, just as it sounds, is going to be atrophic gastritis that's multifocal. It's not associated with the autoimmune function. So you wouldn't see things like the eosinophils and mast cells and all that stuff. And obviously their serum studies would be normal. You also need to consider, again, that H. pylori chronic gastritis. So if you weren't sure about it, you could throw those stains on and they should be negative. Treatment for this, they tend to just give B12 supplementations if they have very low B12 or pernicious anemia. And if they have polyps, they can just surgically excise them or do a polypectomy. And that's typically for the smaller low-grade neuroendocrine tumors. So prognosis, 20 to 40% of these patients will develop hyperplastic polyps, and up to 40% of them can develop dysplasia. So that's something you need to be aware of. Very few of them will develop neuroendocrine tumors, and there's also increased risk of gastric adenocarcinoma. So there's a lot going on with these cases, and they will have to be undergo routine surveillance for that. A lot more slides to kind of show you different examples of autoimmune gastritis, and the chromogranin highlighting those ECL cells. Malignant lesions. And this is our last case of the day.
Okay. It's very blue.
Yes?
So very cellular. Let's take a deeper look. This one's kind of oriented a little funny.
Mm-hmm.
But I think, so we're saying malignant lesion, so there's definitely malignancy somewhere right around here.
Yeah, so now you gotta find it.
Yeah, so, I mean, just looking at this looks more like body / accentic.
I agree with that,
because
yes.
you do get some of the pink and chief and like parietal and then the chief cells. I'll just look around.
I'll let you hunt for a bit, and then I did annotate this to help.
Okay. So it's a small focus?
Yes and no.
Or is it like obvious?
It's kind of obvious once it's pointed out.
Okay. The stroma kind of looks a little funky. Good question. Am I in the right piece?
You were, but here, help is on the way.
Oh, okay.
Take another look at those cells.
Like these cells here?
Mm-hmm.
Yeah, they are large. I mean, that's why I said like this looks funky.
Yeah. And I was like, come on, you can do it. You can do it. I believe in you.
I was just, I was like, let's put a pin here because this is where I would be looking because it's way too cellular for like a normal stroma, I feel, and these cells do stand out quite strong, but they're not really forming any particular, they look like kind of just single cell streaming.
Yeah.
So this is like a poorly differentiated carcinoma.
Love it. Yes.
Okay. Poorly differentiated. I guess you could put some stains on it if you want to determine if you're between the squamous or adeno, but this is like in the stomach, so you should just get adeno technically if it's a primary lesion, right?
Good.
So,
and how about, so what type of lesions are discohesive?
what kind of lesions are discohesive?
Like generally.
Like, sorry, not on the same train of thought here.
Okay. So your lymphomas are discohesive, melanomas, things like lobular carcinomas, but poorly differentiated carcinomas are in that realm too.
Okay.
Yeah. So the stain you'd want to do is basically to prove is this carcinoma.
Okay.
Simply because it's like, yeah, if you're going into those other realms, then you'd want to do a bunch of other stains, right?
Yeah. So, yeah, you could do,
So you get one. I'll give you one.
to determine if it's carcinoma,
Yeah,
you could do a keratin, keratin stain,
like that.
maybe one. It's actually,
Perfect. That's exactly what I'm going to give you. And
alright.
boop.
Okay.
Annotation.
Yeah.
So there's the
So-
cells.
You're like, wow, these shouldn't be here normally.
They're a lot easier to see on this.
Yeah. But yeah, they're there and they're just everywhere and they're not really doing what they're supposed to be doing. They're kind of just
Yeah.
going wild. And social distancing, sort of. You know, they're trying to get away from each other.
Yes, versus our internal control is so strong and diffuse, and they are just crammed up next to each other.
So yeah, so like a fully differentiated adenocarcinoma.
That's great. I don't have anything to add to that. Okay. Fifth most common cancer worldwide, lead third in cause of cancer death. So fairly, like, not insignificant numbers. This tends to, again, be adults greater than 50 years old. Not surprisingly, males more often than females. And so the symptoms with adenocarcinoma of the stomach are very similar to peptic ulcer disease. So that could be anemia, could be emesis, and it could also be weight loss. And the risk factors, are extremely numerous, but things that we went over a little bit today are like our autoimmune gastritis, H. pylori infection. So remember, H. pylori not just associated with multiple lymphoma, but also with gastric cancers of other lineages. You also want to think about genetic syndromes like Lynch syndrome, Peutz-Jeghers, those kinds of things. On endoscopy, this is going to look like carcinoma from pretty much any other site. So it could be polypoid, it could be ulcerated, it could be a plaque. The stomach could just be thickened or infiltrated, and that's your linitis plastica or leather bottle stomach. And this often tends to occur on the lesser curvature of the stomach, and probably because lesser curvature isn't as motile, so things that are there you may not notice for a good amount of time, versus if it's on the greater curvature, it's going to have a lot of stuff hitting it, and it most likely cause symptoms earlier. Or also involving pylorus, it would cause obstructive symptoms most likely earlier, and they present. Okay. Microscopically, you can see two different types. So either it's intestinal type, where it's going to look like adenocarcinoma, or you can have diffuse type, where it's going to be like what we have in our case, where it's really discohesive. And these have a wide range of morphology, so they can be more plasmacytoid, more histiocytic, more eosinophilic, and that's also where your signet ring cell type lives. And about 10% of these will be unclassified, so that's where they kind of just don't fit in any realm really nice. So you're going to see a lot of differentiation, whether it's gastric foveolar cells, intestinal metaplasia. You can also have endocrine type cells, so remember those ECL cells that we saw earlier. And you can also see mucinous adenocarcinoma, adenosquamous carcinoma, squamous cell carcinoma, small cell carcinoma, or simply undifferentiated. If you catch it really early, most of these are going to be well differentiated. Most of them will be intestinal type, and really more often than not they're going to be tubular, but you can also see papillary variant, and some of the early cancers will also be signet ring cell, about a quarter of them. In the pictures, the one on the bottom is highlighting signet ring cells for your stains, so CDX2, CK7, CK20, and HER2 may or may not be present. Your negative stains will be like your Epstein-Barr and also CD44. For molecular, so the molecular for these is a little different from what we saw with like Barrett's esophagus and esophageal adenocarcinoma. So CMET or APC, KRAS, your HER2 aberrations, P53. So a lot of things that you can also see in other areas of the GI tract. Your differential is going to be, is this simply gastric dysplasia? Is it a gastric xanthoma? Is it Whipple disease? And Whipple disease, remember, is infection with Trophirma Whippley. I can spell it. Saying these things, very difficult. I give anyone in micro props because these are very difficult to say. And that's also known as intestinal lipodystrophy. You also need to consider if it has signet ring morphology. Is this a hereditary diffuse gastric cancer? And those have the CDH1 mutation, which can also be associated with your lobular carcinoma. So just remember that those go hand in hand. Treatment for these, they may do gastrectomy, which will, depending on where the tumor is, it could be partial or complete. They're going to do chemo, may do radiation, may do targeted therapy, and targeted therapy would be for things like if they have HER2 mutations. They can also try VEGF receptors. And the prognosis for T1 and T2 tumors is relatively good. Once you hit T3 and T4, the 5-year survival does go down quite a bit, down all the way down to 16% for T4 lesions. Metastasis is often through lymphovascular invasion, so it's not surprising to see these gastric adenocarcinomas crop up in the liver, lung. You can see them in the peritoneum, you can see them in the adrenal gland. So just things to consider. Okay, and then I put together this slide to kind of help with, and this is for like all carcinomas, is the well-differentiated is I can tell exactly what this is. There's just a little more atypia than what I would expect with reactive or normal. Your moderately differentiated is basically I can tell this is carcinoma, or in this case adenocarcinoma, but I can't tell just from an H&E where it's originating from, and also without like history, if all you had was history of the patient has had gastric cancer 5 years ago and they've done a metastatic screen and there's nothing else, then you'd want to select your stains for that. And poorly differentiated is when you're questioning, is this even carcinoma? Or you're looking at going, this is signet ring cell carcinoma. So those are the things to kind of consider.
AKA the WTF cells.
Yes. So that's what we have for this week. There are 18 cases in the challenge cases. Obviously this whole series will not necessarily be an area of strength for me, so if anyone has anything to add, things that I mixed up, messed up, omitted entirely, please let us know. If somebody maybe in the UH system would like to do the GI series, I would happily help with that. But otherwise, if you like this video, despite all its mistakes, please hit like, please hit subscribe, share this on social media. We have our Twitter handles down below. You can check out our videos for other reviews, and we'll see you next week. Oh wait, we'll just grab the mouse so that we can check if there's anything in the chat. Unfortunately, we only have one mouse, so we have to share. Okay, so nope, just my message to everybody. So that's fine, no one has any questions. There we go. So that's what we have for this week. Again, please let us know if there's things that you want to see. And if not, we will see you guys next week, where we will have the WebEx live again, and we'll be covering small intestine.